The pulse cardiac test quantifies damage to the endothelial, the lining of the arteries, by measuring the body's immune response to that injury. It identifies residual risk in the face of other normal markers, and it uses the same information to predict your 5-year risk of having a heart attack. Let's briefly go through the atherosclerosis biology. Free radicals, like oxidized lipid particles, oxidized hemoglobin, or oxidized vitamin C, aggregate on the arterial surface and initiate the lesion. The lesion stimulates production of molecules and recruit leukocytes, monocytes, granulocytes, and T cells to stimulate the production of smooth muscle cells. After the leukocytes are transformed into lipid-laden foam cells, these become responsible for the growth of the lesion. Growth factors are released and stimulate the generation of new capillaries through the process of angiogenesis and provide the growing lesion with an adequate blood supply. The expression of adhesion molecules and chemokines, MCP-1 and others, participate in platelet aggregation, lymphocyte and monocyte adhesion further activating the lesion injury. This results in a physical change to the smooth muscle cells. The process of cell turnover, apoptosis, produces excessive amounts of collagen, elastin, and proteoglycans, transforming the lesion into a fibrous plaque comprised of a lipid core and a thin fibrous cap. This is the unstable lesion or vulnerable plaque. There will still be blood flowing next to the pimple or blister. However, if it became inflamed, it would be unstable. And if the lesion ruptures, it can create the blood clot which prevents blood from going to the heart muscle. This is the hallmark of the vulnerable patient, and we want to prevent this from happening. Calcium scores is the best surrogate for total plaque burden, but it doesn't detect the soft, non-calcified lesions. The PULS test complements coronary artery calcium scores by focusing on initial injuries to the endothelium and detecting necrotic core and fibrofatty lesions, which are the most dangerous. Keep in mind, these lesions may go through transformations over time, as certain drugs like statins and ones used to treat diabetes may cause these to move over to calcified lesions because it stabilizes the lesion. The development of the PULS test used software systems and a set of studies that occurred over approximately a 20-year period. The beginning of the PULS cardiac test involved 2 studies in Kaiser. One was the proof of concept that was able to identify people with the disease at an AUC of 0.92. The second study in Kaiser ranked the biomarkers and determined the optimum algorithm size. It had a hazard ratio of 13.0. Then, we discovered the algorithm while working with the Marshfield Clinic in Wisconsin. We later performed an external verification in transportability with the National Institute of Health. In addition, we've just completed a 10,000-patient observational study, looking at predictors of risk in diabetics and predictors of high risk. Combined, we've looked at 40,715 cases in the process of verification. Here's the process we used to validate the test. First, we looked at the research made to gene expressions in lesions of mice that identified over 250 proteins that were preserved in humans. Through a series of studies, we narrowed down the 250 to about 45 of the most powerful indicators. The next step is where our development diverges from everybody else. We combined all the components of Framingham, like age, sex, diabetic status, and hypertension, with clinically used biomarkers like MPO, HSCRP, LP-PLA2, and BNP, and our biomarkers. Then, we used 3 different statistical software systems to validate the permutations of all these components. All 3 systems identified the same 9 biomarkers and 4 global risk factors. We've found a way to identify who's at risk for ACS in a 5-year period. Our discovery was at the Marshfield cohort, and the population was predominantly Caucasian. So we handed the algorithm to the National Heart, Lung, and Blood Institute, NHLBI, to apply the system to MESA, the multi-ethnic study of atherosclerosis cohort, a well-characterized cohort. The testing confirmed our findings, and 2 of the individuals from the NHLBI became co-authors on our 2012 paper. Only then we released this test for clinical use. We started exploring its use. It had a very high clinical net reclassification index of 43%. PULS cardiac test is a serum blood test that has 13 components. 7 unique proteins related to endothelial injury, 2 proteins from an auto-channel instrument, and 4 global risk factors, which are age, sex, diabetic status, and family history. It's targeted to people 40 years and older, but if patients have a risk factor, like a positive family history or elevated cholesterol, they can have the test performed in their 30s. It was validated against all the most commonly used state-of-the-art gold standard programs and outperformed all of them. The way that we estimate the performance is by using Clinical Net Reclassification Index, which penalizes you for incorrectly up-classifying people and incorrectly down-classifying people. One of the advantages of the pulse cardiac test is that it was equally good at up-classifying and down-classifying patients, where some of the risk calculators currently available mostly down-classify people and are not balanced. These are the 9 clinically significant protein biomarkers used to measure the body's immune response to arterial or endothelial damage. These are the indicators leading to unstable lesion formation and potential rupture. IL-16. The IL-16 is the first signaling molecule. It triggers the repair process and tells cells that have been injured to secrete MCP-3. MCP-3. The MPC-3 recruits monocytes and macrophages, which clean up damaged cells, lipids, and cellular debris. Eotaxin. Eotaxin recruits eosinophils that consume fibrin and prevent blood clots. Eosinophils are typically associated with allergy, and fibrin interferes with the healing process. CTAC. CTAC calls in T cells that regulate the intensity of the local inflammatory response at the site of the lesion. They work together with good cholesterol, HDL, which has a dual function, a potent antitoxidant, and it protects the site from further injury while repairs are going on. SFAS. SFAS prevents cell deaths, something called apoptosis. Fas ligand. If a cell needs to die and be replaced, Fas ligand will predominate. SFAS prevents cell deaths. These two oppose each other, and the predominating one can indicate the state of the injury and its contribution to overall risk. HGF. The hepatocyte growth factor is responsible for something called positive remodeling, when the lesions reorder themselves and become stable. HGF does most of the repairs in lesions. HDL, a potent antitoxidant that protects the site from further injury while repairs are going on. HbA1c. HbA1c is a pro-inflammatory and insulin sensitivity marker. It participates in the repair process as well. Let's look at one of the most important findings that came out of MESA, the multi-ethnic study of atherosclerosis. Patients admitted to the cohort participated in a gold standard workup to determine no evidence of heart disease. At that point, DNA and RNA were extracted, and serum and plasma were frozen. Patients were monitored for a minimum of 8 years. They are now at 13 years. The National Institute of Health took the frozen serum and asked if the pulse cardiac test could predict a significant number of people who had a heart attack. The answer was positive, around 61% in their cohort. They also found that the test had a 97% negative predictive value. This means that the probability of patients with a negative screening test is likely not to have the disease. This helps determining who is a vulnerable patient. Here, we have an example of how individual biomarkers and the current risk profiles fail. Our observational study listed 100 patients from 4 cardiologists. The patients were not pre-selected. This is important because cardiologists are getting referrals from people who have symptoms, and about half of them are expected to be high risk. However, when we looked at the current cardiac risk assessments results, either Lipids, Framingham, or Reynolds, only 6 patients were classified as high risk. Yet, the pulse cardiac test revealed that 47 of these patients were high risk, much closer to what we expected. Observing individual biomarkers like lipids, the high-risk patients are all over the place. The majority of them will be overtreated, while others run the risk of being undertreated. This is the reason why it's very important to have an accurate evaluation of our patients. We are currently not getting accurate evaluation results from the current standards of care test, but the pulse cardiac test augments and improves the accuracy. Let's look at some real-life examples of how the test performs in various scenarios. Ron was 77 years old when we first met him. Ron's pulse cardiac test score was 3.6%, which is normal for his age. He had a positive family history. He'd previously been on blood pressure medication, but was fine now. His BMI was normal, and his blood pressure was normal. Ron came to see us a year later because his daughter was concerned that within the last month, he'd lost his energy. Ron had trouble getting out of bed, didn't want to do things, and thought he was just getting old. However, Ron had been under a tremendous amount of stress over the prior year due to his wife being very ill and almost dying a number of times. His HMO ran the lipid panel on him, and the results came in as normal. His carotid intimal medical thickness was normal, and the rest of his exam was essentially normal. They discharged him and said he was fine. The daughter was still worried and took him to an out-of-network cardiologist for a second opinion. The cardiologist out of network ordered a pulse cardiac test repeat, and the results showed his risk had gone up to 46%, over 8 times what's expected. They sent him back to his HMO, who ran a calcium score, which showed abnormal. They took Ron to angiography and found an almost totally occluded left anterior descending artery. This is the artery of sudden death, and Ron had a trickle of blood flowing through it. The lesion was non-calcified, and this would have imminently killed him within a month or so. You can see how Ron got back a great revascularization. Post-op, he was on maximum medical therapy and looks about 10 years younger. His exercise tolerance is also back to normal. This is an example of how the pulse test can help you be more assertive when looking into your patient's condition. The pulse cardiac test quantifies damage to the lining of the arteries by measuring the body's immune response to that injury. It identifies residual risk in the face of other normal markers, and it uses the same information to predict your 5-year risk of having a heart attack. The development used software systems and a set of studies that occurred over approximately a 20-year period. Combined, we've looked at 40,715 cases in the process of verification. It's targeted to people 40 years and older, but if patients have a risk factor, like a positive family history or elevated cholesterol, they can have the test performed in their 30s. Well done! You've completed Module number 2. Continue to Module 3 when you're ready.